Good afternoon, ladies and gentlemen. It's my great honor to attend this 36th Spring Annual Conference. I'm Hecheng Li from Shanghai Ruijin Hospital. My topic today is robotic pulmonary surgery, history in mainland China and experience of Ruijin Hospital. So I have no conflicts of interest for this talk. As we know, at the end of 2021, there are 260 sets in mainland China established. And we can see here, that's the worldwide procedure trend. You can see from 2016 to 2022, actually, the procedures, robotic surgery has been increased, sharply. This is the thoracic procedure in China currently. At the end of 2021, actually, almost 40,000 cases were conducted in China, mainland China, most of 14% of all the robotic procedures. So what about the robotic pulmonary surgery in mainland China? And we can see this is the report from Shanghai Chest Hospital from Dr. Luo Qingquan. Actually, I guess Dr. Luo first reported his lobectomy procedure in a national journal, in a Chinese version journal. It is two case reports of robotic left lower lobectomy. And then in consecutively, he reported 12 cases of robotic lobectomy. Then in 2019, he reported consecutive 1,000 cases of robotic surgery for pulmonary disease. Another robotic surgeon, a famous robotic surgeon, is Dr. Wang Suming from Shenyang. He reported his case series in 2013, 16 cases of lower lobectomy, and then afterwards he reported several case series. So that's the first two robotic pulmonary surgeons in China. And then here I will give some experience from our hospital, and from two aspects. First, we conducted the procedures from easy procedure to complex procedure. That's wedge resection, lobectomy, to segmentectomy and sleeve resection. And from the clinical study types, we firstly conducted some retrospective study, then do meta-analysis, then prospective clinical trials. That's the first report from our group, because technically we firstly conducted some simple pulmonary procedures, robotic pulmonary procedures. We conducted the first case in 2015, and actually in 2016 we organized the early outcomes of robotic versus uniportal VATS, because for me, I perform uniportal VATS and robotic surgery. And for the first almost 100 cases of robotic surgery, we conducted propensity score matching analysis to compare VATS versus RAS for the simple procedure. It showed that the robotic procedure can reduce bleeding and can harvest more in one lymph nodes, and it was published in EJCTS. Then when we actually have routinely conducted a lobectomy, we moved to segmentectomy. In 2019, we conducted learning curve robotic anatomic segmentectomy and published in the ATS. This maybe gives some suggestions for some junior robotics surgeons. And so for this learning curve study, I found that the learning curve may need 100 cases for segmentectomy if you become an experienced segmentectomy robotic surgeon. Actually, we have routinely performed segmentectomy in our department, so we conducted some multi-center in a real world study. We collected data from 3 big centers and give a PSM study and compare the VATS segmentectomy and the rest segmentectomy, and totally in about 800 cases. This study was published in JTCVS. It shows that for rats, it can harvest more lymph nodes and can have similar other outcomes. And for this study, it was published in JTCVS. Then we conducted some even more precise surgery, say subsegmentectomy, combined subsegmentectomy for the first 16 cases, also published in the ATS. Including, for example, S2B plus S3A and S1 plus 2 and plus S3C and etc. So it shows that for more precise surgery, it is safe and effective. Then we conducted some even more complex surgeries as robotic sleeve resection, and were published in the World Journal of Surgery. Here I give some examples. The first case is a left upper sleeve left upper lobectomy. It is a locally advanced disease and post neoadjuvant chemotherapy. We can see the tumor is locally advanced, and especially for left upper bronchus and the pulmonary artery. So for the pulmonary vein, superior pulmonary vein, it is easy to mobilize and to stable. And after we stable the pulmonary vein, we try to mobilize the PA and control the proximal PA. So I think for the robotic surgery, especially for complex procedures, it should be safe and it should be smooth. So we use a vessel loop to control the proximal PA. Then we remove the left upper lobe to give us enough space. We take away the left upper lobe, then we try to mobilize the left upper bronchus and the PA. Seems like it is an invasion, but we are not sure. So we control the distant PA. Then we use a bulldog to control the distal PA and the proximal PA. So now it will be very safe, right? You can just try to manage the PA and the left upper bronchus. it seems like that it's not tumor invasion, but it's adhesion. And then we retract the PA and give it left upper sleeve resection. Because the robotics procedure is superior to VATS procedure in reconstruction. So the following procedure, the reconstruction of the sleeve resection is quite simple and smooth. So there is no invasion for the PA. So we remove the bulldog and give it a reconstruction. So the following procedure is quite easy. Give it a continuous suture, a running suture for the anastomosis. And the other video is right upper sleeve lobectomy. We can see also a very more advanced disease after neoadjuvant chemotherapy, 2 cycles neoadjuvant chemotherapy. We also control the PA and give it a PA anaplasticity because we resected partial of the lateral wall of the PA. I'm sorry. Then we give it right upper sleeve resection and reconstruction. Okay, we can also conduct some even more precise and complex surgery. You can see here, this is robot-assisted left lingular segmental bronchial sleeve resection. That's for low-grade neoplasm. You can see here the patients, there's a tumor at the orifice of the lingular, and we give it sleeve resection and preserve all the lingular pulmonary. We firstly mobilize the lingular vein and lingular artery and retract the lingular vein and the lingular artery, and to expose the lingular bronchus and sleeve dissect the lingular bronchus. And we use a 5-0 proline to give it an anastomosis and to reconstruct the lingular bronchus. So the pathology is a salivary gland tumor, low-grade tumor. Because the patient is very young, just 30 years old, I think it might be useful to preserve the lingular. To preserve the segment, but just to give it a sleeve resection of the lingular bronchus. So after we have conducted an easy procedure, simple procedure, complex procedure from a lobectomy, segmentectomy to sleeve resection, we then want to evaluate the effect of rats. So we conduct a meta-analysis and was published in EJCTS 2021. 25 studies were included. It showed that rats might have potential long-term survival benefits. It's just like the lymph node harvest advantage in rats. So it might be have potential long-term survival benefits. Then after the retrospective analysis and also after our meta-analysis, we published our prospective clinical trial, say RV-LAB trial, the first trial to compare RAS lobectomy with VATS lobectomy. It was actually a single center clinical trial, and the primary endpoint was 3-year overall survival and extended lymph node dissection. It was published in 2021, April, and just last year. More than 300 patients were included and were divided, randomizedly involved in 2 groups. It showed that for the total amount of chest tube drainage, and for RAS, a little bit more than VATS. Hospitalization costs, RAS is more than VATS. And the perioperative outcome is just very similar. So the RAS versus VATS lobectomy are similar perioperative outcomes, together with a higher lymph node yield. We need further follow-up to observe whether there will be a survival difference or quality of life difference. And this paper was published in Annals of Surgery just last year. And actually, we have more than 6 years experience of robotic surgery. We added a book based on our robotic surgery experiences. That's the robotic thoracic surgery Ruijin hospital experience. We invited some international editors or authors to give their experience together with ours in this book. And actually, we finished our first 1,000 cases in the first 3 and 4 years, and we established our training program in a Ruijin hospital, and including 1 to 3 months short-term observer and a longer period of fellow. So in the end, I'd like to thank you all for your attention, and also I'd like to give my thanks to my team members. Thank you all for your attention.